Today, our guest of honor is Professor Gazi Huri from Aspetar, Qatar. Dr. Huri is a distinguished orthopedic surgeon specializing in shoulder and knee surgery. He currently works at Aspetar, a FIFA Medical Center of Excellence in Doha, Qatar, while also serving as Professor of Orthopedics at the Hacettepe University Faculty of Medicine in Ankara, Turkey. Professor Huri completed his medical education and orthopedic residency at the Hacettepe University, one of Turkey's most respected academic medical centers. He later pursued a specialized shoulder surgery fellowship at the Johns Hopkins University in the United States, where he advanced his expertise in arthroscopy and reconstructive procedures. He has published more than 100 peer-reviewed articles and is the author of 4 textbooks on shoulder surgery, with a 4th currently in preparation. Professor Huri is an active member of the American Shoulder and Elbow Society and as well as the Association of Bone and Joint Surgeons in the United States. So today is my great honor to introduce you to Professor Gazi Huri from Aspetar, Qatar. Over to you, Gazi.
Dear Hitesh, thank you very much, first of all, for the kind introduction. It's my great pleasure and honor to be part of that great platform, Orthopedic Principles, one of the most famous and the most followed platform in orthopedic field. Thank you very much. It's my great honor. Dear audience, dear guests, after a short introduction, I will just introduce. My name is Gazi Huri. I'm currently working in Qatar, in Aspetar, FIFA Center of Excellence. So this is our team. We have very distinguished sports surgeon in Aspetar. Today we are working. You may know most of them from the many meetings and publications, and I have the privilege that working here. We have many good collaborations and affiliations with worldwide sports organizations such as FIFA, International Olympic Committees, and also we are serving as the medical partner of the Paris Saint-Germain and such big clubs. Just I want to say warm hi to all of you just before giving my talk. Today my talk will be about acromioclavicular joint injuries, which is a really one of the most less published topics and one of the most controversial topic ever. Before the controversial, you can find some of the chapters from the books that we published previously in last 8 years about shoulder fundamentals of shoulder and also easy planning for shoulder, including the arthroplasty. So since I told you that I am a part of the big sports surgery organization, we are treating such big names as you see in this slide. Definitely you need to be very precise. You need to find out the best way. And that's why we are always not following the standards. We are always following the individual approach to the sports surgery. Individual approach means, first of all, we need to do the accurate diagnosis of the problems. If we are talking about the AC joint, we need to do the accurate diagnosis of the AC joint. And it should be, our treatment should be evidence-based and ethical, definitely. Not for short-term health focus. It should be long-term. Even if there are many concerns about the return to plate, it should be like long-term benefits by the treatment options that you are going to provide for the sports athletes. And of course it should be that interdisciplinary coordination. Just surgery, the best surgery is not always get the best results. You need to have a very big team. So this is one of our Turkish national Olympic level judo player. Just you can easily see he just gets injured on the direct fall on the shoulder, and he come up with these such AC joint injury. So this is the main question: what we are going to do in this controversial topic. This is the in-season or off-season, or what kind of sports the athlete is involved, or isn't, even if it's not sports. How to deal with all these cases. And I'm going to wrap up all controversial topics, including the last 3 years most updated literature and my experiences together in that topic. So first of all, we need to understand what is the mechanism of the injury. Everybody like thinks that it's a kind of like clavicle goes up, and the misunderstanding of the mechanism. When I see the young surgeons or like trauma surgeons, I can say, they want to push the clavicle back in its origin place. No, the injury is not something like this. As you see in the video, the complete shoulder blade displaced inferiorly. So this is a kind of like, in orthopedic field, we all name the injury according to the distal joint. So that's why it's an acromioclavicular joint, which the whole shoulder blades moves inferiorly. What we need to do, we need to suspend the shoulder back to the up, not push the clavicle back to its original place, like to hold it. When you are in your clinic and you have such an cosmetic problem as well as an acromioclavicular joint, in addition to the functional impairment, what to do? This is the main question: how to do your individualized approach in that cases. Before Dear audience, before talking about the acromioclavicular joint or what kind of surgery that is going to be the best, we need to know about how acromioclavicular joint moves. Regarding the acromioclavicular joint, the AC joint moves in three planes. The first one, as you see, is the horizontal plane. Horizontal plane includes an internal rotation and an external rotation, as you see in the diagram. And the internal rotation is resisted by the AC and CC ligament in addition to the external rotation. The other plane is the coronal plane, so we call it scapular abduction and adduction. And also in that plane, there is a slightly inferior translation of the acromioclavicular joint, which is also very important. These two plane is supported by the AC joint, and the bone contact is also quite important, and the meniscal disc is also important in this coronal plane motion. The third position, the third plane that the acromioclavicular joint moves is the sagittal plane, as you see also in the movie. It's a long rotational axis, and it is only supported by conoid ligament. So these are the whole ligaments that, or the anatomic structures that we need to address if we are talking about the AC joint injury. Regarding this, I just want to raise a question. Which ligament is the most important? The AC ligament, trapezoid, conoid, or CA ligament? And regarding the treatment, which ligament should we repair or reconstruct? It should be the other question: arthroscopic technique or mini open or completely open technique. What are the differences about this? And these are the main questions. Regarding the biomechanical studies, I will show you some such scenarios of the AC joint injuries. But first of all, when you check these videos, these diagrams, it mimics when all these four ligaments are intact. So you can easily see the blue bars just next to the movies that it has an resistant force which is between like in terms of vertical intact, vertical movement, rotational moment, and abduction moment. All they are like, don't care about the numbers, take care about the green bars, okay? So for the first scenario, if I take only the AC ligament off, what happens to the shoulder joint? Like according to the Rockwood classification, it is like type 1, 2, something like this. The inferior moment of the AC joint, you see, it doesn't affect it that much. So that's why the shoulder doesn't move downward. On the other hand, there is a big resistance lack on loose on internal rotation, even in scapular abduction. So you can easily see that if only AC ligament is gone, even if it's not seen on the x-rays, even if it's in the stress x-rays, there is a big problem, big lack of internal rotational stability, and also abduction and adduction means like coronal plane stability, even just one AC joint. And another scenario, if we take off the AC plus trapezoid off to the model, what happens? It is almost similar when we cut the AC joint. So when we get the trapezoid out, almost nothing changed that much because the vertical movement is almost similar with non-intact or just AC isolated injury, and the scapular adduction impairment is as similar as the only isolated AC joint, AC ligament injury. When you go to the scenario 3, if we have a sort of like AC dislocation and we decided to go with the surgery, what we are doing, we are only in the single technique, we are only reconstructing with the suspensory system the conoid. So when we put the conoid, look at that, the inferior translation, the power, the resistance force is better than the normal, better than the natural one. On the other hand, there is no rotational, even adduction and abduction stability. So, unfortunately, this is the most common surgical procedures that we perform now in the literature when we talk about AC joint injuries, the only suspension system. But you see, it's completely insufficient, especially in rotational and abduction of the scapula. And if we add waiver done into that repair plus a C ligament internal bracing, you can easily see inferior translation solved. Rotation better than just isolated suspension system, but still abduction stability is not good. So just to wrap up, we have an AC joint injury. We put the conoid with a suspensory system. We just get an AC joint bracing, internal bracing system, and add the waiver done. All even we do all this process, you can easily see that the rotation is not also solved. It's a big problem. That's why in my practice, this is the most common classification that we are using in AC joint injuries, like called Rockwood classification from 1 to 6. I'm not gonna talk about like deep in it. The most problematic one is always type 3, because type 3 we say like just only we don't know what amount of the ligaments are affected or ruptured. So definitely we know that there is an AC ruptured, but on the other hand, we are not able to understand the conoid or trapezoid ligament, even if which one is complete ruptured or partially ruptured. So this is always a gray zone of the AC joint, and also a very controversial topic for discussion in terms of the treatment. That's why nowadays in the studies, this classification may not be adequate, especially addressing the horizontal and rotational stability. That's why in my practice, I started to almost get MRI in type 3 lesions in order to understand the current position of the conoid and trapezoid ligaments, to be honest. This is a new classification which is described by the ISICO study group, which I really like it, and they divided the type 3 injury into type 3A and B according to the radiological findings. Type 3A is type 3 with no overriding of the distal clavicle in the sagittal plane, and type 3B is the overriding of distal clavicle in sagittal plane, because in the coronal plane in AP x-rays mostly they see like in the same level or a little bit slightly over, but when you do on the lateral side like a sagittal view, like a Stryker notch or something like this, or you go with a CT scan, you may see in some cases the overriding, which is really painful and rotationally unstable. And also it is proven by the literature that the MRI is better to understand the type 3 injury pattern in terms of when you compare with the radiological analysis. The most important, we need to know which we want to repair first, what to repair, which technique, and when. These are the main questions of the treatment algorithm. So in terms of the technique, I am almost routinely perform shoulder arthroscopy, even if it's an isolated AC joint injury, because according to the meta-analysis, all these studies that I will show you, mostly published in last couple years, it's a good meta-analysis. And according to the 47 studies with acute acromioclavicular joint injuries, including Rockwood 3 to 5, all the studies, some is like 860 patients, 20% has the intra-articular lesions. And what are these lesions? The most common are biceps tendon pathologies, and the other is rotator cuff lesions. So that is why in sports athletes, especially with or high demand patients, it's better to get an MRI to understand the concomitant pathologies and not to miss the other problems in additional to AC joint. So this is one of the topic that I want to mention. Arthroscopic, definitely assisted or arthroscopical evaluation intraarticular pathologies. And there is an also very current consensus comes from ISA and ESCA members. It's a Delphi consensus, and they asked to all the group about the treatment options. Most of them get an arthroscopic assisted anatomic reconstruction with a suspensory device. It's more than the group has like 80% is using these suspension systems in order to get the AC joint reconstruction. But they mentioned I have some concerns about isolated AC joint suspension because of the biomechanical studies as well. And this is another study which also compares the arthroscopic stabilization to the other techniques. It's a 32 patients, acute, grade 3 to 5. Mean follow-up is quite good, like more than 5 years. And arthroscopic stabilization has the satisfactory results in long-term studies in terms of the all PROS, which analog scale, simple solder test, or other functional outcomes as well. Additionally, if you think about like, okay, I'm not expert to do it in arthroscopic assisted AC joint reconstruction, what is the other technique? Of course, you can go with some other mini open techniques or the open techniques. And this is a study also published from United Kingdom. It's a kind of also a meta-analysis, 17 studies compared the mini open technique versus the arthroscopic technique, and definitely there is no difference in these two techniques in terms of the results. And in addition to that result, some sort of anatomic reconstruction of CCCA ligament and AC ligament is also very mentioned as a very important factor. So this is another study, also compares with the mini open versus arthroscopic double tightrope technique. It includes 19 patients arthroscopic, 26 on patient mini open with an acute type 5 injuries. And when you compare it, there is no difference, and both groups has excellent results in terms of the recovery of the athletic capacity in high competitive patients. And what happens in acute cases? So we need to know that acute is completely different from the chronic cases. For me, if it is like more than 3 weeks, it becomes a chronic case for me, not for me, for the literature as well. So this is for the acute cases. When you do the surgery within these 3 weeks, it's a study about it. What happens to the CC ligaments? They took 33 patients, minimum 2 years of follow-up, operated with a technique of suspensory system, and they monitorized the healing of CC ligament with MRI, and they saw that in the MRI CC ligament healed. But definitely, it's not an histological study, so I cannot say the quality of the healing or the quality of the collagen, the type of the collagen, because according to that study, they didn't get any histological data, but at least a kind of like fibrosis bridges, we can say, is existing if the cases get operated early, not to wait more than 3 months with minor comorbidities. And as I mentioned, acute versus chronic. This is also one of the most important topics that we discuss about it. There is a study about acute versus chronic cases. Definitely, it's a retrospective study published. They took the patients 3B according to the ISACOS to 5. The number of the patients were equal, 33 to 33, totally 66 patients. And regarding to the acute versus chronic cases, this is definitely conclude that early arthroscopic assisted treatment, even we can say like early treatment options with a cortical fixation, is definitely better than delayed surgical interventions. This is another analysis. So they had 26 studies over 1,500 patients, including 3 to 5, and they tried multiple triple treatment options in that study. And according to that study, AC joint fixation with graft augmentation definitely improves the outcomes. In addition to suspensionary system, longer, it's the disadvantage. Yes, you need to open the AC joint. You need to use a graft. In my routine, I use allograft instead of autograft. Surgery time exceeds like more than maybe get longer, about like 20-25 minutes, but the stability and the outcomes really, like the recurrence rates are really less also in my hands, as I mentioned in that study. So this is one of a national player I want to show you. It's a very different type of injury. So yeah, he got the ball on his head and he just immediately fell on his shoulder. So he is 25 years old professional football player. It's an acute injury. And just after the injury, like he has a look, you can easily see the mechanism of fall direct on his lateral shoulder. You can Yeah, he got it and the head, and you can easily see the right shoulder direct fall, and he was not able to keep going with the plane. So, and this was this patient came with this injury, and it was the surgical treatment of that case, suspensionary system plus ACCC, allograft ligament reconstruction, and this patient 1.5 months, which is the very, he get back to the pitch, and he was quite happy with that. This is another patient, 27 years old, male, is a motocross, professional motocross sport athletes. It's a chronic case. He just show up in my clinic with this big bump on his shoulder, and this was the X-ray on his case. It was a chronic case, and definitely I use in that case ACCC ligament reconstruction with the tunnel technique. That's why I didn't use any button system, and this patient get a good outcome also, I can say. Another type of AC or CC ligament injury is a distal clavicle fractures. According to the according to the NEAR, like it's an unstable fracture, we can easily see. And also I treat, and the literature also support us to treat these kind of fractures as the type 5 CC ligament reconstruction or ligament injuries, AC injuries. I stopped using hook plates for many years ago, and after that it was like only 3 months follow-up. This patient has a very happy, it's a kind of like arthroscopic assisted, it's a close fluoroscope assisted surgery with a minimally invasive technique that also I reconstructed CC ligament. This is a cyclist. He had an open AC joint reconstruction in the another center, 38 years old. He is a cyclist. He came to me 1 year post-op with an unstable AC joint. When you check this X-rays, it doesn't look like that bad. But when you check his microscopically in his physical examination, you can also easily see the big bump on his shoulder when you stress do any stress. But on the other hand, for the 3D reconstruction of the shoulder joint, you can easily see the overlap. Like it's like we can even say type 3B overlap of the clavicle over the acromion, which is also painful and really symptomatic, as happened in that case. And what I did this guy, like this intraoperative, he has an unstable AC joint, like it's a piano sign. You can see like it is, the shoulder is moving up. And I revised the suspensory system and plus put an AC/CC ligament reconstruction at the end of the surgery, and now is quite well and doing perfect. Always there is but, I can say. This is one of the reasons that I stopped doing only suspensory system, because of the stress rising on some bones, like in the clavicle. I had one case is that a clavicle fracture in that case, and then you can easily see when I expose, it was like a kind of like a knife. It just cut the clavicle into two. If the patient is a high demand and a big guy, only suspension system may not be enough in terms of getting the rudder stability. And as I mentioned, this is another case in the previous one. So I published this paper in 2017, I guess, or 16, I'm not sure. I was dealing with like some minimally invasive techniques for the ACCC ligament that I don't want to touch the bone. So this is the technique, the minimally invasive technique that I described in terms of the ACCC ligament leg reconstruction with just only polyethylene, it's a big tape, as you see on the right down corner. Um, I will show the video a little bit more if you want any questions. And then in that case, in this study, it's like a case series. It's not that long one. I just get the tape, subacute tunnel. I modified this technique. It's a kind of like artificial tape, artificial ligament, but it's not a ligament for sure. In that study, I just reconstruct the CC ligament like a belt. And then now I modified it and I used the rest of the strip, the rest of the tape to reconstruct or to brace the AC joint. So now the results becomes better, but even I just put this one, the complication rate, I have in that case, very small amount of patients, but even for my practice, I have quite low complication rates in that case. So as you see, this is a tape. It's a kind of belt, and there are some very easy instruments. You can see, I'll just get the tape under the clavicle. Yeah. And you will see here, this one now on my laser. I'm putting like a belt. Yeah. And I'm pulling it. I'm gonna pull it. When I pull it, it just sits over the clavicle. And then I have a tensioner for that in order to provide the reduction as well. It's a tension system. Yeah. It just turns around and around. Yeah. This is a technique. Yeah, you just get closer with your tensioner. Just load the nut into your tensioner and then get your tension while you are reducing the AC joint. So this is what I do, and then I secure the tape with a screwdriver, like we did in the spine surgeries. Yeah. So this is the technique when I do. Also, it's also useful for the revision cases if you don't want to create new holes or something. It really makes your life easier, as I see in that case. So what happened to my guy here? Definitely, he got the gold medal after the CC ligament reconstruction because the results were quite well. So, to sum up, what is my algorithm in Aspetar in sports athletes? If it's Rockwood type 1, 2, I definitely go with primary non-operative treatment. If it's 4 to 6, I primary operate these guys. Even some studies have say like type 5 has no difference in the long term, but for the high demand patient, it's really hard to convince the patients to do that. If it's type 3, as I mentioned, and also the literature support to get an MRI, and if MRI, the whole CC and the conoidal, trapezoid, and AC ligament are torn, and if the patient is a high demand or an athlete, I go to primary operative treatment. On the other hand, I prefer to wait a little bit and to be on the non-operative side. If it's a non-operative side, it's a successful follow-up, no functional impairment, return to play, return to activity in type 3. But if it fails, even for the non-operative treatment, I do go for the secondary operative treatment for the chronic AC joint reconstruction. So in summary, definitely dynamic stabilization is our gold standard rather than buzzword screws. Conoid reconstructions with AC ligament repair or reconstruction or bracing are highly recommended in the literature. According to the biomechanics study, trapezoid ligament does not affect the stability. That's why two tunnels only may increase the double tunnel, double trouble. In clavicle, and also this is I don't do it, but according to the literature, waiver done may increase the stability if you can find the ligaments. You can scan this for my LinkedIn. I will be happy to answer your questions. Thank you very much. And just a reminder and just an announcement, sorry, 9 to 11 October in Aspetar, where we are organizing Aspetar World Conference, including the orthopedic surgery, sports medicine, and physiotherapy. And there will be more than 100 topics that will be discussed about the sports, and many distinguished speakers will be together. We will be more than happy to have you here. Thank you very much for your attention. If we have, I will be happy to get the answers, to answer the questions.
Thank you, Gazi. Thank you, Gazi, for this wonderful presentation. You covered almost the entire spectrum. Gazi, a few questions.
Yeah.
Now, Gazi, in one of the pictures, you showed that when you put a loop alone, the button alone, there was a fracture of the clavicle, right? Because one of
Yes.
the reasons it's a very thin structure, right? And sharp.
Yeah.
Do you think a tendon graft, which is broader, thicker, would be a good choice instead of using just the loop? I think in one of the images you have put the tendon graft, but what about routinely instead of using the tape and or the suture button, put the graft?
Hitesh, it's one of the case. I only put the graft. I definitely agree with your decision. But routinely, I do suspension like we call it like dog bone. Now it's not the issue that to mention about the name. I put a dog bone, not the thin one, the big one, in order to get less stress rising, and also I augment it with the tendon definitely. Because you know why? Tendon is more dynamic than the suspensory system. But if we are dealing with the athletes, you need to have more stable construct to make them return to play early. That's why I combine this two technique. But what I learned during more than 10 years definitely address the AC joint. We just think about like CC ligament, like endo button, suspension, perfect. No, it's perfect just early post-op. And then it loses.
Yeah,
So
that's
unless
good.
you
Good
repair
point.
the AC joint,
Yeah,
you have to do both, right?
yes, absolutely.
That's the
AC
point.
joint. Yeah,
So,
absolutely.
like what is happening is there's a trend to only CC and leave the AC, but that's
Yeah,
not right.
yeah, I agree.
Okay, Loiy, you're welcome to the show.
Yeah, that's a
Loiy
good
is
point.
an orthopedic and sports medicine surgeon in Dubai. He's a flourishing orthopedic surgeon, big practice. Loiy, welcome to the show. And questions you guys.
Thanks, guys. Thanks, Gazi. Wonderful, wonderful, wonderful talk. I like the presentation. I like the movement of this AC joint. It's sometimes hard to understand the internal rotation, external rotation, the AP, the horizontal instability. Really important concepts that you highlighted tonight. So let me ask you, we do have a few questions for me. As a fellowship trained shoulder surgeon, let me
Mhm.
ask you about your rehab protocol for, as you are coming from Aspetar, we know Aspetar is a big name in
Yeah.
sports, your rehab protocol after surgical versus non-surgical treatment. Is there any difference?
Yeah, absolutely difference. Absolutely, Loy. Very good question. If you go with the conservative treatment, you need to protect the arm's length. You need to keep the arm's length a little bit more than the normal. It means like you duplicate the time. So in terms of the if you do an stable construct, including suspension system plus the allograft reconstruction augmented. So we just put the sling as tolerated, we remove it. Maximum 10 days for the sling. But if we go with the type 3 or for type 4 something, not 4, like 5, and if we go the conservative treatment, you need to keep the sling at least 4 weeks, which is really painful for the athletes.
Do you still
Particularly,
do the stress views?
no. Stress
Not
views,
anymore.
no anymore. I do MRI more than stress views now to address the conoid and trapezoid ligaments.
So one of the questions that keep popping up is there any specific sports that you really push in or recommend initially aggressively that you will go for surgery, early
Yeah.
surgical early surgery? Is there any specific sports that you say, oh, listen, you are doing this type of sports, please go for surgery?
Yes, the definitely rugby, definitely rugby players, football players, football like American football, and also martial arts.
Yeah.
So
So this is
these,
high
yeah,
contact.
high contact. Yes. So
Exactly. This is a take-home message. So one of the issues that you mentioned, they did it well. I liked it that the tightrope that you did. For me, what I learned, at least they at 20% they will loosen up. So what I do, I just over reduce it, just a touch over reduce it because over time it will loosen up.
yeah,
And this is what something I learned. So that takes us to another question. When you place your tunnels, how do you make sure this is really an anatomical tunnel and it will mimic the native CC ligament? You need to go up to
yes,
down.
yeah,
This is not really the case because if you
yeah,
just tilt to either side, you might end up with a creep. Sorry,
yeah.
you might end up with the button will loosen button or will come the button will come out and so on.
So there are very good question, Loy. The position of the tunnel in clavicle and the position of the tunnel in coracoid. So sometimes we see. First, let me talk about the clavicle position. So this is the line. So this is the line. Okay, coracoid and the clavicle should be on the same line, right? So this
Yep.
is the medial side and this is the lateral side.
Mhm.
The worst scenario to put your clavicle tunnel in the medial side because it's going to pull the clavicle, the acromion, over the clavicle. So it's gonna be like disaster. This is a big mistake. No medial. If you have a good fluoroscopy, I do fluoroscopy. I just check the just a footprint like in the same direction. Or if you have something like a fracture case or something like as I show you, you can put a little bit more lateral, but definitely no medial for clavicle. And for coracoid, there is also studies about the tunnel placement like this, on like an oblique, from like a superior, like medial or lateral or the direct. So the only thing what changes if you make an oblique tunnel on the coracoid, your button doesn't sit like this. If it sits like this or like that, this amount of 20% of loosening will happen immediately. It's not
Yeah,
about re-rupture, yes, but it will lose up.
yeah, that's maybe that will give us the next question was how would you revise this tightrope failure after tightrope? Would you replace the tightrope and add an allograft, or what's your strategy after
So
failing?
yeah, one case I show you, the case that I revised. Definitely, I go first of all with the CT scan to understand, to measure the tunnels, the position of the tunnels, and then I prefer rather to use the same tunnels if they are okay, then create a new tunnel. But if I need to create a new tunnel, I go quite deep to the base of the coracoid a little bit to hold the tunnel to have the good purchase of the bone. But if the tunnel is not like usable, or there is something like I cannot use properly, I do only soft tissue reconstruction. And also there
I
is
see.
this, there is also like, I didn't do that, but I read like 6 months ago probably, pectoralis minor transfer to the clavicle as a salvage procedure. Keep in your mind it, because if you break the coracoid, yeah, maybe another point, maybe the audience may go today and check how they can use the pectoralis minor to treat the AC joint if the coracoid is broken in the middle of the case.
That's a good
I hope it doesn't
point,
happen.
and something
Yeah.
first to be mentioned in one of the webinars. Amazing. So, how do you treat the residual instability, or how do you suspect them? This residual instability is persistent pain. Is pain dependent on activity? Certain activities when they lift their shoulder up. How do you suspect and you go for treatment?
So most of them in the chronic cases, they come with click, they come with pain, like arthritic changes. So this is like, first of all, it starts if you catch it in the early phases, you get the instability of the over movement of the joint, like hypermobile of the joint, hypermobility. But on the other hand, if it becomes chronic and chronic, you start to see, especially in type 3. In type 5, I don't think it's going to happen, but in type 3, it's more prone to get AC joint arthritis than the type 5 because of the impairment of the motion. Like even it's going up a little bit, but you have also touch between the two bones. And in that cases, in chronic cases, pain is more seen, but in acute cases, especially, the patient hears like clicks, some discomfort, and also, of course, the instability of when they're holding something like lifting an heavy object from the somewhere, whatever, from market
Yeah.
back, they cannot do it.
Amazing. I think that's all what we got for
Yeah,
questions
and
tonight.
and Gazi, see, I just want to give the benefit to the audience. See, when you have a chronic AC dislocation, right? Like you said, pain is a concern, and the traditional surgery has been weaver done. You have mentioned that you
Yeah,
do a distal clavicle excision and you do a CA ligament transfer.
yeah,
So,
correct.
do you think that's a very reliable surgery in a chronic dislocation? I'm not talking acute, in a chronic situation where pain is the concern.
Hitesh, it's really hard. I know you guys do many shoulder also in the chronic cases. We talk about the chronic cases, if I all open it, even with my finger, I cannot reduce it. It's because it's a full of fibrosis everywhere. So that's why uh, I don't only trust waiver done procedure to manage the chronic cases, definitely. So for me, you need to reconstruct the AC, CC, and in additionally, you can get the CA ligament if available. But most of the cases, you cannot do it. You cannot find it even. To be honest, it's not easy
Yeah,
to.
it's a very small tissue. It's
Very
been
small.
described for years, decades,
Yeah,
but
no, that's
in
why I think we are
practical,
talking
it's
about.
difficult.
It
Getting
becomes
the
like
ligament.
it becomes like old-fashioned. So I was in Isakos last month. We discussed. I was in the panel for AC joints. So any of the authors also not doing waiver down procedure that
Great.
much. Yeah.
Great. I think that's all the questions that we have for this session, Gazi. Thank you for this spectacular
Thank you.
session, and we really look forward for more in the future.
Thank you very much.
Thanks,
Goodbye.
Gazi. Good night. Cheers.
No.